Hello, my name is Ryan Bixel, and without any delay, here is my presentation on pericardial effusion. Now you might be asking yourself, just as I did many times before familiarity set in, what exactly is pericardial effusion? The pericardial effusion is accumulation of fluid between the muscular outer layer of the heart and the thin fibrous pericardial sac that surrounds it. Now, in a healthy individual, the pericardial sac generally contains about 15 to 50 milliliters of serous plasma. And that plasma, which you can kind of see in this background picture right here, so here's your sac, here's the heart wall, so this is showing an excessive amount of fluid buildup. So that fluid is usually there as a lubricating agent, so the pericardial sac and the heart, as they move in a living body, they don't stick to anything. Now, in a healthy individual, there's generally somewhere between 15 and 50 milliliters of fluid. It just depends on a number of things, hemodynamics in the body, how big your patient is, etc., etc. There's multiple things that can cause fluid to start accumulating, whether it's trauma, infection, which leads to inflammation, many things that can either delay the absorption and drainage of the pericardial fluid or can produce an excessive amount of pericardial fluid, which will lead to fluid buildup. Disease etiology and process is complex and it can vary on a case-by-case basis. If it's left untreated, pericardial effusion can have many results. The most prevalent, but not really prevalent, one of them better known but not as commonly occurring, is what's known as a cardiac tamponade, and we will get into that a little bit later. The long and short of it is, as that fluid builds up, it's going to inhibit the heart's motion, which means blood isn't going to get pumped. This will lead to blood pressure issues, oxygenation and perfusion issues, but again, we'll get to this on another slide. I've noted here two columns, one for adults and one for children. These are common causes of pericardial effusions in both the pediatric and the adult population. Pericardial effusions are more often than not thought to be either bacterial or viral in nature until a better diagnostic is made. There are certain cancers that can cause a pericardial effusion, whether it's of the heart, the lungs, the trachea, just anything in that thoracic cavity that can inhibit the heart's pumping and motion can lead to fluid buildup. Other organ disorders such as thyroid or kidney failure, kidneys especially, I'll often educate my liver failure patients that your filtering process in the body has an important job, and if those are not working, then that fluid has to back up somewhere. Drugs or medications is also another very common cause. If you ever look into the list, many of the drugs that have anti-insert your body function here purposes, such as antihypertensive, antiemetics, anti-tumor, anything that can essentially prolong your QT interval on your EKG rhythm can also lead to effusions. Now in children, since there aren't as many pre-existing conditions or exposure conditions that can cause a pericardial effusion, more often than not they're congenital in nature, and so it can be caused by a connective tissue disorder or even an autoimmune or genetic disorder. Lupus is one of the most prevalent causes of pericardial effusions in children. Not that it happens often, but it does. Infections, either viral or bacterial, can also be causes of a pericardial effusion. Quick story, I worked with a nurse and her daughter had been married for about 2 years, and in the first year of her marriage, at 22 years old, she got pneumonia, and she actually ended up developing a pericardial effusion, was in the hospital for several weeks just because her pneumonia had complicated things to the point where her body started to back up fluid around the lungs, around the heart. So yes, many different things that can cause a pericardial effusion. Signs and symptoms of a pericardial effusion. I did add tamponade on here, but we'll get to that on the next slide. The most common presenting signs and symptoms are shortness of breath and chest pain. When the heart is inhibited, it's going to feel it, and the rest of your body is going to feel it. General feelings of malaise, just unwellness, decreases in blood pressure, increased heart rate or heart palpitations. These are things that the patient is going to experience, but the most common signs are shortness of breath, chest pain, swelling. Now, in a pediatric population, anybody with children will tell you that children aren't always the most articulate. They just don't have the vocabulary. They can't tell you, ow, my chest hurts, or hey, I don't feel like I can breathe very well. So they're going to present in different ways, just as sick children often do. Things such as change in appetite habits. They're going to become more lethargic, especially if they're not feeling well. Most children kind of lack that lustrous childlike energy. They'll be more irritable or prone to seeking comforting activities. My children in particular, I've noticed when they're not feeling well, they just want to be right next to you, right on top of you, and they don't want to move. They just want to know that you're there and be comforted by your presence, your touch, etc. Now here we are, the cardiac tamponade, one of the most dangerous occurrences that come about because of a pericardial effusion. As I mentioned earlier, a tamponade effectively occurs when the heart is so compressed because of the fluid that's built up in the sac around it that it is inefficiently circulating blood, creating oxygenation and perfusion, which leads to hemodynamic instabilities and decreased available oxygen. Signs or symptoms or diagnostic criteria for a cardiac tamponade, as we see here, the Beck's triad. So you'll be hypotensive. You'll start seeing jugular venous distension. Again, if the atria are still pumping but the ventricles are not, you're going to have venous backup, and most notably it'll start causing the venous distension or the swelling in the neck, the trunk, the upper extremities of your patient. It'll also lead to EKG changes, just because if those muscles are not able to effectively conduct an electrical signal because they're not moving effectively, then you'll start to notice anomalies in your EKG. This is a medical emergency. It needs to be dealt with swiftly and immediately, or it could lead to patient demise. Year-old male, he came into the emergency room with acute onset of chest pain and shortness of breath. During his interview, he reports that he's had a general feeling of malaise and some mild leg swelling that he's noticed over the last several days after caring for his children at home. About 10 days ago, and then at another time, he went to an urgent care because of his shortness of breath and feeling of malaise. He said that he was given some antibiotics and told to follow up if the symptoms did not resolve. As a healthcare provider and as a nurse, generally you'll do a more in-depth interview and start laying your basic groundwork. You'll get a baseline set of vital signs. You'll do a head-to-toe assessment, get an idea of what the patient's overall presentation is currently. And then we get into the diagnostic assessments and criterias. When coming into the emergency room, blood work is almost always one of the very first things that a doctor will call for. There's a general panel such as a CBC or a complete blood count, a complete metabolic count. Your complete blood count, the CBC, that's going to give you red blood cells, white blood cells, platelets. It's going to tell you if there's any coagulopathies. It might suggest bleeding or anemia. White blood cells, kind of the baseline diagnostic for any sign of infection or inflammation in the body. Complete metabolic panel, electrolytes, kidneys, liver. This is going to tell you if there is an imbalance in the system. It'll start giving you a suggested idea of where that imbalance might be occurring and what's currently going on in the patient's body. High sensitivity troponin will be a rule-out diagnostic. This is a cardiac marker that is present in the event that the cardiac muscle gets damaged. Most often it's used in the case of a myocardial infarct. Procalcitonin and D-dimer. These ones are not as often used, but again, with these specific sets of symptoms that the patient presents with, they might often be called for. Procalcitonin is abundant during a bacterial infection. So if there are bacteria somewhere in the body, generally your procalcitonin will respond accordingly, so that'll give you a slightly more differentiated result than just your standard white blood cell count, which will tell you that infection is taking place. This can tell you if it's bacterial or if it's not. And then the D-dimer shows the breakdown of blood clots in the vasculature. It's a really easy rule out for whether or not the patient has or recently had a stroke or an embolism somewhere. Diagnostic imaging is also going to be very common. John should probably get a chest x-ray and a chest CT. That's kind of baseline for his presenting symptoms. Chest x-ray is going to show dense structures with fluid being opaque. If there's anything going on there, especially pneumonia or in our case the pericardial effusion, if it's severe enough, it might start showing up on the chest x-ray. I have an image of a chest x-ray right here. So here we can see the lungs, these nice big black open spaces. There shouldn't really ever be anything in the lungs, and so they present as big black empty spaces. The heart should also generally present, it might be a little bit more dense, but in this picture we can see this nice dark or this nice white opacity that shows that, hey, there is something there that should not show up on a normal x-ray, which can lead to further diagnostic testing. A chest CT is kind of the gold standard for diagnosing or identifying a pericardial effusion. Here you can see the heart within the pericardial sac. And generally, you shouldn't see the pericardial sac at all, but as you can see with these indicating arrows right here, the sac is larger in area than the heart, and so it's showing up on your chest CT scan. Echocardiography can also be used, and that's this bottom picture right here. It's not the most reliable just because there's a lot of factors that can inhibit its functionality, but it can still give you an idea of how effectively the heart is beating, which can in turn suggest that there's fluid or something inhibiting the beating of the heart. So again, as we said earlier, the course of treatment is often determined by the severity or the progression of the disease, or by what symptoms the patient is presenting with. If there's enough fluid built up, or if the symptoms are severe enough, or if a cardiac tamponade is occurring, then first thing that the doctors are going to want to do is perform a pericardiocentesis. Now this is not a terribly invasive procedure, but it is a procedure nonetheless. So the doctor is going to use a local anesthetic to kind of numb the tissue in the patient's chest wall, so the skin and heart, you can see right there. This guy's had a pericardiocentesis. And then using a needle, they'll go through the skin, through the chest wall until they've punctured the pericardial sac, as we can see in this image right here. At that point, practice is left more up to experience, preference, things like that, but they will either leave the needle or, more often than not, a catheter will be inserted and then they'll start extracting that fluid from the patient's pericardial sac. Now, one thing to be aware of, just like in having a paracentesis, there is a risk of removing too much fluid too fast, and so there's a limit to how much fluid that the doctors will generally use, because if you take too much out too quickly, you can develop what's called pericardial decompression syndrome, which will result in pulmonary hypertension because too much fluid is trying to shift in the patient's body, or it can shock the heart, and the heart can start beating in an anomalous way, or it can even cause a full arrest if the fluid shift is severe enough. Now, post-procedurally, generally one of the first things that will happen after admission is patient will be placed on cardiac telemetry, and then a wide-spectrum antibiotic will be used not only as a first line of defense for the causative agent until it's identified through serological studies, but also because any kind of procedure, there is a risk that there could be an introduction of a pathogen into the patient, and so we'll start giving them antibiotics. Generally Zosyn or piperacillin and tazobactam is one of the first lines of defense. And then the patient will be with you for a couple days until such a time that there is little to no production in the pericardial drain or JP bulb or whatever suction or fluid removal system is put in place. And then at that time they'll pull the tube and monitor the patient for perhaps a couple more hours, and then they'll be sent on their merry way. At this point, follow-up is generally directed by the cardiologist. They will be managing care from there. The patient will also be following up with his primary care provider or otherwise, but cardiology is going to be the key follow-up there. And they will kind of direct prevention strategies as well. Very easy prevention strategies that can be implemented are frequent hand hygiene, especially during cold and flu season. Just being aware of who you're around, and if you're around people who are sick, make sure you're washing your hands and taking whatever preventive measures are going to keep you from getting sick. You don't want to reintroduce that pathogen back into your body. And again, hand hygiene, very, very important. There are other measures such as making a heart-healthy diet, limiting alcohol intake, regular exercise especially is very important because movement is not only going to help increase the health in your body, but it's going to help with fluid resorption and help prevent fluid accumulation again. And then also, did I mention that hand hygiene is very important in infection prevention?